excited. Thank you for that last presentation on Canada. It was wonderful. Appreciate it. Let's give Phil and Blair another round of applause. As someone who's lived in Canada, it's striking how a close neighbor can actually be so different in culture and implementation of things. I'm really excited to introduce you all to Dr. Barbara Bazron, who is in charge of behavioral health here, not here, over there across the water in Washington, D.C. I met Barbara when we were both at Oxford House, which if you haven't been to an Oxford House conference, I would recommend that you go. You can imagine a room of, I'm not exaggerating, about 5,000 recovery advocates, rousing recovery advocates, talking about the importance of sober housing and recovery. It was incredibly inspirational, but I was so honored to be on the panel with, on stage with Barbara and just learn so much of the innovative things that are happening in Washington, D.C. I don't have the matching awesome outfit with green on green. I love it. The last time I wore all green was in second grade when I was the Mad Hatter, if you can believe it, which makes sense actually, kind of Mad Hatter, in Alice in Wonderland, and my mom made me a green suit, green shoes. Maybe I need to go back to that, but anyhow, this is very exciting to be here. So Dr. Bazron, maybe you could just speak for a few moments about kind of your position and how you got into this field.
Yes, first of all, good afternoon to all of you who are here with us, and thank you for being here today. As you said earlier, I am the director of the Department of Behavioral Health for the great state of the District of Columbia. So, really happy to be here to join you. I think that for all of us, our path to wherever we are going to be is probably checkered for the most part. I started out as a special ed teacher, teaching young people with social and emotional disturbances. And from that experience, I was then actually recruited by the Lumen Group to lead the National Resource Center on Perinatal Substance Abuse. Of course, I said, I know nothing about that. Why are you trying to hire me, And what he said was that they really wanted a leader to come in and really run this national program. So we had an opportunity to provide technical assistance and support to the postpartum women's and infants programs all over the country. And through that, I learned an enormous amount about substance use prevention, intervention, treatment, and recovery. And from that point to this day, I believe that prevention, intervention, and treatment work and recovery is possible for everyone. And I have to tell you, one of the most inspirational things I learned, and I want to give a shout out to people in recovery who serve as peers. They really are the most critical element of our service system. And I have continued from that point forward to make sure that peers were at every level within the organizations that I have had the pleasure of leading. Following that, I actually went out into the private sector again and became the managing director of the American Institutes for Research, where I had an opportunity to begin to do some study and some work around co-occurring disorders. Substance use disorders do not happen in the absence of life. And in many instances, mental health concerns are a part of that. And so if we are really to provide treatment for individuals who are impacted by this disease, we have to treat the whole person. And that means both mental health care as well as substance use care. And oh, by the way, also looking at the social determinants of health, which will make the difference. I also served as the senior deputy director for the Department of then Mental Health within the District of Columbia. At that point, we only worked with mental health, and then in 2013, we had changes in our statutory responsibility, and we took over substance use disorders. And so one of my roles was to integrate substance use and mental health disorders. And I found that those were two different worlds, two different cultures. And we really had to work to make sure that we could have a seamless service. From then, I did leave the District of Columbia and go to Maryland, where I served as the Deputy Secretary for Behavioral Health, which was very instructional for me because I learned how states work. The District of Columbia is a city, a county, and a state. And it functions very differently from a traditional state. And so that was very useful. And then now I currently am serving in the capacity as the director. I was very, very pleased when Mayor Bowser invited me to come back and do this work here within a city that I really love.
That's great, thank you, Dr. I want to dive right in. Washington, D.C., and many people know this here, and I think it's on their minds, has a really unique approach to the marijuana issue. It's one of the really only contingent where it's essentially a sort of grow and gifting model version of that we really haven't seen anywhere else. And of course, there's been push for retail and sales and all that on the political side. And obviously, what from your perch as a head of behavioral health, I'm just curious to see what changes you've seen since, let's say in the last 5 to 10 years, since there's kind of been more than normalization in the district. I think for the average person visiting Washington, like the average person visiting New York City, you can smell a change, literally. And so, but in terms of you look at the data, you see what's happening, especially with your work with, in perinatal and postpartum populations, which we're seeing skyrocketing use. What has been the impact from your observation?
Well, I think first of all, one of the things I do want to be really clear about, and that is there's a difference between decriminalization and legalization. And I've heard the word legalization used throughout the day as I've sat here. Within the District of Columbia, we have decriminalized the use of marijuana. It is not legal. And so what that means is it is not unusual on my way to work or around town to see people walking down the street smoking a J. So, I mean, it's like you said, you can smell it, you can see it. The issue that we face is our young people also see that. Mom is at home, dad is at home, they're smoking on the street, they're smoking in the house, and so it's very difficult to talk about. So this isn't something that you need to do. However, we feel very strongly that prevention and healthy decision making is key for our young people. So the manner in which so the manner in which we have approached it, I think some of you probably had the opportunity to hear from members of our prevention centers. We do fund 4 prevention centers that serve all 8 wards within the District of Columbia. Those centers are extremely important, not only in pushing out information to families and community members, but also to our youth. We also have youth leaders that are trained with the appropriate and accurate information and talked to about how to convey those messages to their peers. And I can tell you, there's nothing like going into a room with these hundreds of young people who are all learning and eager to hear about the facts and what needs to happen differently to keep their friends from going down the abyss of substance use disorders. Years ago, I remember reading studies that talked about marijuana as a gateway drug. How many of you remember that? Some of you are older than I am up in here, yeah, okay. And so we really haven't talked a lot about that. But I think we have to really have young people understand healthy decision-making is really critical because it can really change the course of your life. As a result, one of the things that we have done within the Department of Behavioral Health is we have mandated that all of our school-based behavioral health clinicians offer Too Good for Drugs, which is an evidence-based curriculum for young people that helps them around healthy decision-making. The District of Columbia is, based on my research, one of the few places in the country where the key leaders, meaning our Mayor Bowser and the council, have made funds available for there to be a school-based clinician in every school within the District of Columbia. And so, you gotta go where children are. You have to provide them with information and have those conversations. We as adults have to do it, but it's also important for our peer leaders to do the same. So that is the way we are approaching it within the district.
That's great, thank you. Shifting a little bit to this idea, we talked a little bit yesterday and today about harm reduction and how it kind of has a million definitions, for a million definitions among 500 people. I mean, there's just so many different definitions that every person has of it, and it means different things in different contexts. One of the things we talked about at Oxford House, I remember, was the innovation you all are doing here with your stabilization centers and that version of harm reduction. We've seen in New York City, now we're going to be seeing in Rhode Island and some other places, kind of folks take that extra step, which I don't think the evidence is there yet, of effectiveness of the injection sites and sort of this idea of places to go where you can safely use and also get other resources and food and housing and blankets and etc. But obviously it's a place to use drugs. You've done something different here in Washington. You have not done that before. You've done something that I feel like tries to capture the best of some of those good intentions of that outreach, but leaving out maybe the stuff that really can be a slippery slope to further addiction, because we know there's no sort of safe way to use drugs. So maybe you can talk a little bit about that.
Yeah, first of all, I like to say that for me, harm reduction is all about keeping people alive. You can't get people into recovery if they're not here. You can't. And so one of the things that we look at is what do we need to put in place so that we can keep people alive. We know that moving into recovery is a change process. So it means we have to build relationships. It means we have to really treat every single person as a very important person, as a VIP. And we have to walk with them down that road in a manner that they feel most comfortable. So in terms of harm reduction, we've done a number of things. And I think that one of the things we've done to keep people alive is we've saturated our community with naloxone. Saturated. People can get naloxone here in the district by simply texting Live Long DC to 888-811. We will deliver it to your house. We will tell you where to pick it up. We will mail it to you. We also have vending machines located throughout our community where people can simply go and get it from the vending machines if that's the way they choose to do it. I carry naloxone with me all the time. It's in my handbag, which is there under the table, because I never know when I'm going to use it. I cannot tell you how important it is to be able to immediately use naloxone to keep people alive. We do free training. We teach people about the Good Samaritan Act so that people are not afraid to use it. So I think that that's one of the things that I'm very proud of in terms of how we're doing it. We also give away free fentanyl test strips because we know right now fentanyl is almost in everything, marijuana included. And so we need people to be able to test their drug so that they can make the decision as to whether or not they're really going to use it or not. And if they're going to use it, to make sure that they're not using alone, so that somebody is there with them who can revive them using naloxone. So I think that's very important. Some other pieces of our harm reduction framework is to make sure that we have a full continuum of services all across our community. So all of our hospitals, for example, test people who come into the hospital, both in the emergency room, and those on the floor using expert. So we can identify individuals who may be at risk, and we can begin that conversation. We also have co-located teams with our fire and emergency medical center. So there are mental health professionals, there are peers riding with EMS. Because what we learned was that even though EMS could call us and say, we have somebody, can you come talk to them? Because we just revived them. By the time we got there, the person had walked away. And so now we have the person there. So that's a part of our harm reduction process. The other thing I think that's really important is outreach and engagement. This is all about relationships. Our folks are out there on the street every day building those relationships with people who are suffering with this disease, so that we can talk about what services are available, how you get them, and we will walk you to them if you want to. And I think that that's also important. Another couple of things that we have in terms of our structure is that we also have services in our jail. We have a specialized unit for both men as well as women. Everybody in the jail upon release leaves with naloxone. And also we have a ready center that connects them to care. What we know is overdose is most likely within the first 30 days. And so we want to make sure of that. And so, having that full continuum of services and supports, and being willing really to build those relationships is key to our harm reduction efforts.
So maybe just a minute on stabilization.
Okay, all right, okay. I am so excited. A little over a year ago, after doing some research and going to various places around the country, we decided to create a stabilization center. And we use the word stabilization center because words matter. A lot of places you will hear called a sobering center. Ours is not a sobering center, it is a stabilization center. To position people so that they can begin to think about recovery. We've developed one at 35 K Street, which is where our urgent care clinic is located. It operates 24/7. People can come at any time of the day or night. A couple of key things about the stabilization center that I think are important. One is that when we first started out, we had developed a relationship with our fire and emergency medical services. And one of the things that they were interested in was actually decreasing the number of individuals who went to emergency rooms, because their ambulances were being tied up in an emergency room. So we arranged for that kind of transport, so they found someone on the street and they could bring them directly to the stabilization center. When we began, 99% of the folks who came through Fire and Emergency Medical Center. Now, a little bit more than a year later, we have had 7,666 visits. Think about that. It's almost 8,000 visits for almost 2,400 unique individuals. And of those, 2,400 22% have gone into care. That's 22% of people who may no longer be here. So I think that that's also important. We have really realized a lot of positive things with our stabilization center. A couple of things I want to tell you is, I told you earlier that originally about 90% of the people who came to the center were brought there by fire and emergency medical. Now it's about 44%. The word is out. People now know this is a safe place to come. It's a place where people respect you. It's a place where you can get the help you need. We provide medical screening on the front end. We also give people meals, and one of the things that I've learned, because I kind of hang out in the lobby, you know, and talk to people as they're leaving the center, is that the food is really good. And so they do come. And one gentleman said to me, he said, you know, he said, I come here because I am really treated with respect. And that to me is a culture that we wanted to build within this center. The other thing we know is that this is a journey. We had one gentleman who had been to the center 50 times. 50 times. And on that 50th time, he said, I'm ready. I'm going to go into care. When somebody says that, we will immediately take them. I didn't say send them. We take them to care, and so that they can get the services and supports they need. When they are through that process, we also have environmental stability, housing, and recovery housing and supports, because people have to have a clean and safe place to live. And so we actually utilize every single possibility, not only our SOAR grant money, but our opioid abatement money, as well as Medicaid, to provide this service. We plan to do a second stabilization center. It is in process right now in another ward. And I must tell you, I can't tell you how many council members. I just had my oversight hearing yesterday, day before yesterday. Everyone wants a stabilization center in their community, in their ward. And think about that. Think about how that destigmatizes this particular type of harm reduction. To have one in your, that we want one, as opposed to saying, get them out.
Which is different in a lot of communities with methadone clinics and all.
We're methadone clinics, yeah. And so I think that that's very important. I do encourage all of us to remember that this is, you know, really a journey, and that prevention, intervention, and treatment works, and recovery really is possible for everyone.
I don't think there's a better way